my title, and what I want to do is take you on the journey of my research, and not just my research, but many collaborators. And as Bert said, I have grown, as it were, into someone who wants to foster interdisciplinary research, and I hope you'll see that through my talk. And so the work that I present is the work of many hundreds of people, and many thousands of interviewers probably over the years, if we top them up. But I really wanted to talk about population studies and population studies across time, and I'm going to illustrate them with the research that I've been part of and have been privileged to lead, and also to try and think about how that relates to policy, practice and research as I go along, sort of weaving it through, and also the relationship to the challenges that we face as human societies, particularly the understanding of global and national inequalities and brain health in this regard. So just to sort of set the scene, and this is from somebody who's now a postdoc, Yutsu Wu, Dr. Wu, who's up in Newcastle now, but she did her PhD with me. And she did a review, a kind of qualitative narrative review of population-based studies of incidence and prevalence of dementia that were able to look across generations. But as part of that work, she drew this picture, which I think is really helpful in terms of understanding just how different aging is for different populations, and how different aging is across generations. And sometimes there are things that shock us globally, like COVID or the flu pandemic 100 years ago. And sometimes there are things that shock countries, like economic kind of downturns or crises of one kind or another. And what you can see here is for the countries that were in the review that she did, you can see there's quite a variety. There's a general trend for an increase in life expectancy across that time. And as epidemiology students, you'll all know how life expectancy is calculated, a sort of instantaneous snapshot of mortality in a single year in these cases, and as though you lived your whole life in that year. And what you can see is from quite a low point for some, there's been this increase, but also there are these shocks which occur for First World War, Second World War, but also the other things like polio epidemics and so on. And of course, this will influence aging, how we age, although we have, to some extent, tended to ignore this. The other thing that we have perhaps not paid sufficient attention to, although it's been staring us in plain sight, is the nature of the aging population. So we talk about having older people in the population and the increase in numbers and the increase in the world's population because of increased life expectancy, but we don't talk so much about the fact that within aging there is this massive heterogeneity, and that partly arises from the fact that it's such a big age range. So if you, depending on where you start older age, but if it's from 65 onwards, that a 90-year-old is very different from a 65-year-old, and I'll talk a bit more about that. But also that the proportion of the world's populations and countries' populations made up of those age groups is going to change across time as well, with far greater proportion being in the 100 plus or the 90 plus age groups, and that our research hasn't really kept up with that fact that a very significant proportion of our population will be in these old age groups. So we really need to look at older people in their population context, and we need to do it. We need to keep updating it as well, and that I hope will become clear in my talk. And we need to understand what the disorders are in contemporary populations and check whether they are the same as they were in previous generations. Because anybody who has done any gardening will know that you can't assume that one plant will do as well as another in a different context, even if it's from the same seed packet. They do very differently depending on how they're handled, and so do we as humans. We are no different in terms of the way that we live, or we kind of evolve during our own lives. And so dementia and cognitive change across aging occurs in that context of history, community, and life course health influences. And this is just a couple of images of On the right-hand side, it's actually participants in our research, and on the left-hand side, it's just beautiful, beautiful artistry. And there isn't so much artistry of older people that is really beautiful, and this is just one particular image that I think is really lovely. So within aging, of course, there are many conditions that we should be interested in and are interested in, but dementia has dominated really since, I guess, the 80s and 90s in terms of societies and policymakers being concerned about the impact, because it has such an impact on families, households, communities, and societies, and the way that we support and care for our older people who are frail cognitively. But the moment you look as an epidemiologist at the notion of dementia, which is often talked about as a disease, you realize that it's not a clear-cut disease. It's a syndrome, and it's got fuzzy edges, and those fuzzy edges are particularly influenced by changing environments and fashions, and that influences the way that dementia is seen in communities. And we have also got fashions that influence the way that we see the subtyping of dementia. So if you were a social anthropologist looking at dementia, you'd want to examine the evolution of the concept of dementia across time, and also the way that the subtypes have evolved in relation to what's going on in wider society. So the syndrome is dimensional because cognition, the ability to function, and the exclusion criterion for the dementia syndrome are pretty well all dimensional. Well, they are all dimensional, really. There's very little in life that's 0-1, as Jeffrey Rose taught us many, many years ago. And the subtypes are our own kind of creations. So Alzheimer's, vascular, which went out of fashion and then came back, and Lewy body disease, which was created a few decades ago, and then the increasing recognition of dementia with Parkinson's disease, and then more recently things like hippocampal sclerosis and the role of laying down different proteins in the brain, different proteins from the ones that are seen in Parkinson's disease and what is called Alzheimer's disease, and indeed some of the changes in the vasculature of the brain. And then, of course, then even more complicated from our point of view as epidemiologists is the mixed, which went out of the window when the criteria were made in 84 and beyond. And yet what we see in the brain is lots of mixed dementia. And then, of course, there are the whole raft of other causes of dementia, such as alcohol, infection, COVID, possibly, HIV, trauma, and so on. So they're all, these all contribute to what a country or a nation or an individual experiences as dementia. So our tendency to split and reduce has been perhaps not that helpful if we're thinking about dementia from an epidemiological and a population perspective, particularly from a public health perspective. And that's where epidemiology can sometimes sort of be a bit too reductionist, and one needs to bring in sort of thinking about populations and public health in a more holistic way, and trying to understand the detail of the bits that you explode the dementia syndrome out into, how it fits into the gestalt of dementia in an individual and in the population. So I came into this field a long time ago in the mid-80s, and I was actually a pure medical epidemiologist at the time, having come through general medicine, or what you would call internal medicine. And I was taught to examine the thing very carefully. And so I did in the 80s, and looked at pretty well read every literature bit that was around, every bit of literature that was around. In those days, you did it all manually. And the evidence base at the time really showed that it wasn't binary, that dementia was much more complicated than was being suggested. And there was a clear need from an epidemiological point of view. And I remember talking to Bert about it in detail at the time, to deconstruct the criteria for dementia at the time and measure all the different variables that you possibly could in a population. And so I did it in the way that I could in the UK, and Bert did it on a much grander scale in the Netherlands, in the Rotterdam study. But basically, I went on to deeply phenotype a population of women aged 70 to 79 with the methods, the best methods that were available at the time. But that didn't include imaging, of course, that's much too long ago. And I used standardized instruments, which then were quite novel in this field. And they led to a kind of much more rigorous and steady diagnosis of dementia. Up to that point, studies of dementia had rather kind of just gone on clinical judgment rather than using systematic approaches to coming to the diagnosis. So I did neurological and cardiovascular examination in place, and actually took bloods and spun them at home, put them in the fridge. You wouldn't be able to do any of that kind of thing now. So it's really interesting how things have changed across time about what's possible and what isn't. So that's really just sort of laying the ground from the years and years ago. What that study revealed was that basically the syndrome measures, all of the measures that make up the diagnosis of dementia, were continuously distributed, including those which were used at the time for subtyping, particularly the vascular scales, and that age and education sort of influenced performance quite heavily. And in a 5-year follow-up, informant and self-report memory problems were predictive of dementia occurring, but not on an individual basis. And this is where kind of prediction for groups and prediction for individuals really comes apart. You really need to think about the role of the measures in and their value for an individual versus thinking about groups. I did try to follow up for autopsy because I was really interested in the deep phenotyping, and I only got one brain, and that was from the person who happened to come to autopsy anyway, who had a brain tumor. And I had seen her not all that long before she died, but and she had the top score of anybody in the population that I saw. So that taught me that you need to be really careful about making assumptions about what somebody's brain might look like on the basis of their clinical status and vice versa. And I'll come back to that. So the distribution, this is just an illustration of the distributions, and Bert might remember this from the Lancet paper that I published that he wrote a letter on at one point. And so I was making the case that because cognition was continuously distributed in the population and cognition had been associated with neuropathology, that neuropathology would also be continuously distributed in the population. So that was the earliest study. And then in parallel, at the same time in Cambridge, so this was I was in a rural area north of Cambridge City, UK. And in the city itself, Daniel O'Connor was setting up a larger study, a much larger study on over 2,000 people aged 75 and over, to test models of care in the population. And that study then turned into a classical epidemiological cohort study of the old, and with an ability to look at prevalence, incidence, and risk for dementia, and a whole range of other things. Because the great thing about doing a population-based study is that you can look at multiple features of a population and also look at their interrelationship. Which instead of looking in silos and focusing on specific disorders and to the exclusion of everything else. So that study was community and care homes, which was a feature of the UK population at the time. You could sample easily. It's nothing like as easy now. And he had roughly the same measures that I had in the rural study. And it was a fantastic response rate. You don't see those response rates these days. And I was fortunate when Daniel moved back to Australia, I became one of the lead investigators for this study. And so ever since then, I kind of took over the study. And we have had lots of follow-ups and a brain donation program. And I'll show you just a few of the results, but the really early results, which I think is probably one of the most influential publications, certainly for Europe, that set off the dementia research world and also the heavily influenced policy, was Eurodem, which Bert led, bringing together all of us in Europe who had conducted prevalence studies of dementia in populations where the methods had been sufficiently robust. And that led to these early estimates, and these are all very kind of pertinent now. That these are the prevalence estimates for dementia in all these different populations around Europe. And on the left, it's the kind of crude results, and on the right, it's logarithmic scale on the y-axis. And you can see this incredible relationship with age, which we have ignored, I think, wrongly in our very biological research. Often age has been ignored, for example, in animal models. And I just think it's really important to always show this slide because it shows this incredibly strong relationship of dementia with age, so that there's something fundamental going on with age that is important to dementia. We also showed in this study that, again, the continuous distribution of change in cognition, again, suggesting that dementia is very much on a continuum with normal aging, and normal aging has some decline. So the modal or the average decline across a couple of years in the populations that we saw in CC75C, the 75 plus, was a point drop in the mini mental state. That's the cognitive test that was the kind of major test within that study. So that sort of led that kind of reinforced the sense that if you're looking at dementia, you need to look at the whole population. You need to look across the spectrum without simply looking at cases and controls. I mentioned the brain donation program. So we weren't able to do sort of detailed phenotyping in terms of huge bloods and imaging and so on in the way that the Rotterdam study, but we were able to do brain donation, and that was one of our lovely brain donors. And it's unselected, so it's not the usual type of brain bank where you've got cases and sort of rather strange controls who come through weird routes. This is a true population study where it's unselected who comes to brain donation. And it was a very successful program with over 240 brains. And this is a reconstruction of an artificial sort of case control approach to test, as it were, to challenge the clinical type outputs and clinical and neuropathological outputs that were going at the time. And what you can see here is if you artificially create a normal group, a kind of supernormal group from the population who've died, and look at their neuropathology, they've got lower levels of neuropathology which are associated with Alzheimer's. So this is tangle pathology and plaque pathology in the brain, and the green, you can see they're relatively low levels of those pathologies in the brains of people who've died without dementia. And then, so that's control. And then the red are the moderate to severe dementia, people with dementia who die. And you can see there's plenty of pathology. There's overlap with the so-called normals, but they are, a lot of biomedical literature looks like this, and the conclusion would be they were very different populations, very different and easily separable. And that isn't really the case. And this illustrates the fuller picture, which is that you have a continuum of pathological changes in the brain. So indeed, the hypothesis in the original Lancet article, which was that there was a continuum of pathology in the brains of people in the population, was shown in this particular analysis, and has been shown obviously by many others since. So it really does show this continuum. This is now well accepted, but it was quite fairly heretical at the time. The other thing that I mentioned about the disconnect between the clinical status and the neuropathological findings at death is illustrated by this slide, which is a Cambridge City over 75 brains. And the light grey pillars are people who die without dementia, and the dark grey, the people who die with dementia. And it's these are kind of classical pathologies, so tangles, plaques, angiopathy in the vessels, so protein deposition in the vessels, and vascular disease. And I think the thing that sort of jumps out at you is the overlap and the lack of separation of the two distributions. And this is in people who are in their 9th decade. Most of our brain donors are from CC75C are in their 9th and 10th decades. So something is happening in the older population about dementia expression that isn't related to these particular pathologies, because clearly there are lots of people who've got lots of the pathologies who aren't demented when they die. And it's very important. It's a very important finding for biomedical science, but still rather neglected, even though these are old findings. So now I'll move on to the cognitive function and aging studies, which Bert kindly mentioned. And this is a big set of studies that were started in the early 90s. So they kind of evolved out of that early work that was being done. And there were a bunch of European studies being initiated at roughly the same time. And it's population-based, multi-institutional, 18,000 people at baseline. And we brought all the methods and learning across from all those earlier studies. And that started in 1989, probably before some of you were born. And then just to note, there's a new generation study, which was sampled from 3 of these sites, from Ely, Nottingham, and Newcastle, was set up in around 2010 to do a new generation study to compare contemporary populations at that time, because it's already 10 years out of date now, with the earlier 1990 studies. Key findings from this batch of studies will follow now. And clearly the key one is this extraordinary finding. I mean, I was so surprised that the prevalence of dementia had dropped between the generations. So the 1990 generation is shown in blue, and the 2010 generations are shown in red. So this is not a follow-up study. This is a new sampling in the same geographical localities, and the prevalence, and there's hardly any overlap of individuals as it happens. And what it shows is that there's a more than 20% drop in the prevalence of dementia across generations. And this is clearly hugely important. I didn't think, because of this strong relationship with age, I didn't think that this kind of change in dementia in the population was possible. So when we unblinded the results, because it was quite a complicated study to do, we basically had to do a massive sensitivity tests to just try to break those results to see whether they really held up, and they did. The slide behind, or the figure behind, is the incidence rates, which also dropped by 20%. And that was largely driven by a very large drop in men. So these kinds of studies, of course, allow you to do this risk factor analysis. And those of you who are studying dementia will know the risk factor profiles very well. I just note the striking risk associated with age, 90 plus to 65 to 69 is 25 times, and everything else pales into insignificance, but of course is not insignificant. It's still important: gender, education, stroke, Parkinson's disease in particular. And these and the results from so many cohorts, or well, a limited number of cohorts across the world, but have contributed to the systematic reviews of dementia that I'll refer to later. But basically, this is hard graft on the ground doing primary research, and is what we need if we're going to understand dementia in populations. So coming back to this sort of disconnect between clinical and expression, this is a striking finding from the brains of our donors from the cognitive function and aging studies. And this shows, interestingly, that there's a consistent relationship between dementia and atrophy, dementia expression and atrophy, whatever age you're at. You can see those two lines are fairly parallel in terms of the changes in the proportion of people who have atrophy, either dying without dementia or with dementia. And on the right-hand side, what you can see is something quite different, which is that the Alzheimer type pathology appears to be kind of expressing itself differently across the age groups. Of course, these are people who've died, but that the relationship between the expression of dementia and death and the presence of plaques as an illustration of Alzheimer type pathology kind of disappears as you get into the older old. So this just reinforces the earlier findings that of that disconnect between the clinical status before death and the neuropathology, and therefore other things are going on in the brain in the older old. And if you're justifying all your research on the basis of biomedical findings in younger, you're justifying research on the basis of the Alzheimer's disease and the burden of dementia in the older old, you need to be studying the older old, not basing it on the younger old, in whom, as you can see from this slide, there's a very nice differentiation between the people who express dementia and the people who don't in the younger age groups, like 75. And this was pretty difficult to calculate, but Fiona Matthews, who has been working with me on CFAS for many, many years, and is in Newcastle, was in Cambridge at the Biostatistics Unit, but she worked out a way to develop an attributable risk analysis for the brains that we had from this study. And the striking thing here is that the Alzheimer type pathology, which is usually cited as being 60% of dementia, or sort of contributing to 60% of dementia in terms of pathology, is kind of comes down a lot if you look at a population sample and you put age, brain weight, vascular pathology and other pathologies in, and then it takes its place, as it were, and it's just 20%. So we've got 20% roughly for age, really 90 plus, 20% for brain weight, low brain weight, 20% for Alzheimer's type pathology, vascular pathology is about 20%, and then other pathologies. And this doesn't include the TDP-43, but it would go up slightly. I think it goes up to 17% if you take the new hippocampal sclerosis type analyses into account. So this helps us sort of think about what direction are we going in with our understanding of the underlying etiology of dementia in the population. And it also allows us to think about things like why don't people develop dementia if they've got pathology? So one of the things that we could do with the brain population that we have, and this is an analysis from 3 population brain donation studies. That's the Vanta study in Finland, the CC75C and CFAS. So that's around 1,000 brains. And we were able to look at education and the expression of dementia given particular levels of pathology. And what you can see here is that, and it's illustrated with cortical tangles here, which again, classical Alzheimer type pathology, at different levels of pathology. For each of those levels of pathology, people who have higher education are less likely to express dementia. So it's over and above. So it's not a difference in the amount of pathology that they have Alzheimer type pathology in this case. It's actually that they have the same amount of pathology, but they have less expression of clinical dementia. And this feeds into a lot of work that's going on around the world on compensation and protection of the brain through other mechanisms, which may be mediated through completely different mechanisms, neurological sort of mechanisms and environmental mechanisms in the brain, such as synaptic density and so on. And I'm presenting dementia as a binary in those analyses, but what we see, of course, is if you look at the cognitive, if we look at cognitive change across time, it's continuously distributed, as I noted earlier from the other studies. But we can also kind of categorize them and do different types of modeling with using different states. So in this analysis, it's no impairment, slight impairment, moderate impairment, and severe impairment using mini mental state categorization. And it's about people, so we follow people up across time, and then you can see how they transition between the different states. And this is the probability of moving between different states and then dying. And what this revealed to us is that people who have higher education, stronger occupational complexity, higher social and intellectual engagement in later life. So that's kind of a cognitive lifestyle was the term. I don't quite like it, but it was, everybody's exposure was divided into tertiles. And so we had a top, middle and lower tertile for those 3 things, those 3 life stages. And that combined, as it were, a whole life course lifestyle led to quite different transitions between these states. So no impairment to slight impairment. If you're in the top tertile, you are less likely to even go into that state, and you are much more likely to recover. So as you can see, 0.58 and 2.93. So you can see that you've got an advantage if you're in that top tertile. And then not much going on with the slight impairment and the moderate impairment. But if you come to the severe impairment, if you're in the top tertile, you die faster. So this feeds into the literature that there is about the kind of compression of morbidity that the advantaged lives allow you to approach death for longer with less disability, well, certainly in cognitive terms. And then when you do develop cognitive impairment, then you die faster. Of course, it won't apply to individuals necessarily, but at the group level, this is what we found. So the good thing about these studies is they can kind of allow you to step back and think about concepts and methodologies. And I'm just going to give a few results just to illustrate these areas. Because if you're working in a clinical environment, there are always the filters between the person that you recruit and the population. Of course, there are response biases, and they're pretty extreme now. And we need to work out how to do better population-based studies now. It was easy in the old days. You just went out and recruited people, and you got good response rates. But now it's rather different. But these studies have really allowed us to test the approaches that have been developed in more refined settings. So this was an exercise quite some years ago by Blossom Stefan, who's now a professor in Nottingham. And she did a systematic review of all of the intermediate cognitive states that were being promoted at the time in the early 2000s. Each of the grey diamonds represents one of these particular diagnoses, whether it's age-associated memory impairment or mild cognitive impairment. And she created a snakes and ladders. This is simply an operationalization of each of those criteria. So if you take one individual, you can drop them in and you get 17 different diagnoses according to these different intermediate cognition states. And then you can test the prevalence variation according to all these different approaches and test their outcomes. And I'm just going to show you the 2-year outcome. And what you see in these are all the different criteria at the bottom. And what's important, and what was assumed not to be the case at the time that we were all studying mild cognitive impairments in these different conditions, was that actually it was a very unstable condition, and that people move out of it into other things. And depending on your criteria, you basically pull in people who are more likely to die, who are more likely to revert to normal the next time they're seen. And actually very few, the red is the dementia group at 2 years, the proportion of that particular group who go on to develop dementia. Of course, the prevalence is very variable, but this is fixed at 100% just for comparison of the outcomes. That a minority go on to develop dementia. So this was really important because people were talking about screening for MCI in the population, and that it was going to be, transform services for dementia or outcomes in dementia and so on. But it was very important to know that MCI is inherently unstable, and that a minority of the population who meet the criteria for MCI don't go on to develop dementia. MCI is clearly still, it's still in the clinical setting. But in the clinical setting, you've got a background prevalence which is higher, and therefore the predictive value of the state is better, as you'll know from your teaching. Another thing that, actually this is not from cohort studies, this is from Yutsu Wu's work, whose life expectancy work I presented at the beginning. This is work that she did on a systematic review in China. I wanted to show this because I wanted to just highlight the importance of keeping the diagnostic methods steady if you want to look across time, because the fashions change in terms of who we say is dementia, who has dementia, the boundaries change. And in this study, she did the systematic review, very rigorous, looking at all the methodological underpinning of the studies of prevalence of dementia in China, Taiwan and Hong Kong, and mainland China and Hong Kong. And what she found was that the diagnostic methodology mattered, and that actually this isn't that slide, but that if you look with the diagnostic methods that have changed, it looks as though there's an increase in the prevalence of dementia. But if you hold it steady, if you hold the diagnostic method steady, and account for the differences in the diagnostic method, that the increase in dementia assumed to be occurring in China is not significant, or was not significant at that time. This slide shows the differential between men and women, and shows the huge survival effect in that the women there's just far more women in China who are surviving into the older age groups, and that goes back to my earlier risk slide, which a lot of the risk, the gender aspect of dementia is really still controversial and uncertain, and could still be accounted for by survival effects that men die earlier than women, although that is beginning to obviously change. Another aspect of looking at total populations and looking at all health as well as brain health is that you can look at disability and other health conditions as well, and multimorbidity. This is an analysis that's come out fairly recently on disability-free life expectancy and socioeconomic status, showing the first phase of CFAS, the first generation, and then the second generation for men and women. And what you can see here is that there is a differential with disability and disability-free in terms of life expectancy here, and it is you can see the increase in life expectancy in CFAS2 here on the right, in men on the right. But the life expectancy is still, we've still got that longer period with disability. So trying to disentangle, what is the quality of life? If we're extending life, are we extending the quality of life? What period, what proportion of our lives are then spent with disability or without disability? And the clearest finding from these is not just the increase in life expectancy, but also this gradient, the gradients that the least advantaged have just as much disability in their later life, or just as much disability in their life expectancy as in the earlier era, if not a lot more. So, and both for men and women, there's considerable periods of life spent with disability, and it is sort of, as it were, shorter lives with more disability, and the same thing applies to dementia itself. This slide will be very familiar to many of you, and of course the work that we did it with the narrative review on the cross-generational studies was then followed up by your own department, led by Bert, and I think this has been hugely influential, doing a systematic analysis of the raw data of the studies which have been conducted around the world, which had that time period, were able to look across time at the occurrence, in this case, the incidence of dementia. And it's still not hit the public domain in the way I feel it should do, because this is a very striking and a very positive result that should be informing public health policy. Our work has contributed to the global burden of disease, and this is just a map of the age standardized prevalence as of 2019. And of course, these data are only as good as the studies that go into them. So it's really important that we continue to do primary data research, however difficult it is and however difficult it is to get the money to do it. But there's huge variation across the world, and the GBD exercises are contributing to public health globally. And I've talked about the systematic reviews of risk analysis, and this is the Alzheimer Society, it's actually the Alzheimer's Disease International, nice little infographic on the risk factors that were pulled out in the Lancet Commission on Dementia from the world literature, which look at the front runners on intervenable, modifiable risk factors for dementia, building on the fact that we have demonstrated that there is a reduction in dementia. But the most important thing I think that jumps out of this, it tends to be taken out as an individual, each thing tends to be taken out as an individual thing. What can we do about obesity? What can we do about physical inactivity? Is that these are all associated with inequalities, global inequalities and national inequalities, and within region inequalities, and even within locality inequalities. And that's what really jumps out at me from these risk factors. And as you may be aware, if you kind of put them together, you might come to, I don't know, about 70% being preventable. Some papers kind of put them together, that they stack them up without taking into account their interrelationship. But if you take account of their interrelationship, and make the assumption of causality, 40%, around 40% is what this accounts for dementia overall. And that leads me on to the need, really critical need, for a population approach into dementia risk reduction and healthy aging of the brain, in fact. We've demonstrated collectively between us all, the efforts around the world, that there are life course influences on the occurrence of dementia from birth right through to dementia incidence. And this is a rather nice infographic that Jill Livingston and colleagues created in this snake. And this tries to get the attributable risk sort of visualized, and I think it's quite effective about which are the most important and which aren't. So the potentially modifiable estimate here is 65%. I think it's probably a bit over-aimed. But there are things that are happening at different times of the life course. And of course, as I've said, they all cluster around inequalities. And if we address the inequalities in society and did it in a collective way, we might have far more impact than looking at picking off things individually, where we know that individualized approaches have very limited reach and tend to drive inequalities. So how these have influenced policy, practice and research, the size of the problem, in different settings, prevalence, incidence, care settings, end of life. These studies have contributed primary research findings to all of those areas, and the recognition of key importance of vascular factors and other things like like TDP-43, and also contributed to prevention and risk reduction. And in the UK, it's not an approach I think works particularly the public health from a public health perspective, but our health checks now have dementia risk embedded into them for people to be informed about dementia risk. We've informed screening in primary care, looking at testing before and after policy changes, because the studies have been kind of going on while policy changes have been happening, so you can look before and after, and showing not really that there's any particular benefit, and perhaps some disbenefit to the early detection and the screening mantra. But we don't screen, but there was a kind of very aggressive payment for getting to targets of dementia detection, it was called. And one of the most important things, I think, is that we kind of give a balance to try to inform the biomedical endeavours, because we really need to kind of highlight what is the role of early detection, diagnostics and potential treatments in the context of dementia in the whole population, and kind of push this holistic approach, taking into account multi-morbidity and inequalities in our populations. So that all feeds into having a holistic public health approach with primary prevention, secondary prevention, tertiary prevention integrated, and understanding the individual within their context, both in contemporary society, but also across time, their historical context as well. And that seems to be an incredibly important way for us to kind of develop our research programs into the future. And it's particularly important because if we look across the globe in low and middle income countries, I've been talking about studies in high income country, that areas of life course exposure are really important, and stunting is one. So this is just a figure of stunting around the world. Children who are stunted will not have not optimized brain growth and brain development. If they don't get to school, particularly the girls, they won't have that stimulation. And these are kind of global issues that we really need to tackle. And we also need to tackle these in the context of the Sustainable Development Goals. And I think it's really important that we think about what are the implications for the environment and for our resources, ourselves, fiscal, and fiscal and physical as well, and place our own research in the context of the Sustainable Development Goals and try to make sure that we are doing things that are moving towards them rather than actively contributing to things that are moving against them. So that's my talk. Thank you so much for listening. These are, as I say, hundreds of, well, many tens of wonderful colleagues and team members and participants and their families and the practitioners, the GPs and so on, and the universities that have been involved as well, and the funders. And just a little plug for a textbook that came out relatively recently. Okay, and that's it.